Okay, so we're in the spinal region. Objectives, look at the anatomy, understand some basic spinal cord reflexes, predict some symptoms associated with different spinal cord lesions. So, anatomy, all the stuff you've seen before. The neural structures within the vertebrae, spinal cord, the roots, the spinal nerves, and the meninges. There it is. You've seen this before. Just a couple things to understand or note here is, and let's go back, and one of these days I'll remember to do this again. Before I get started with the lecture, get rid of the mouse click. I don't know why it defaults to that all the time. Okay. So, cervical enlargement, lumbar enlargement. That shouldn't be doing that. Why is it doing that? I just turned that off. Oh, you know, I didn't apply to all the slides. Gosh, I'm getting too old for this stuff, man. I can't keep up with this technology. These young whippersnappers. There we go. All right. Cervical enlargement, lumbar enlargement. And remember, that's because you have a lot more stuff coming in and out of there, sensory and motor stuff coming out for the limbs and the extremities. From a sagittal view, looking at the spinal cord sitting in here, in the cervical spine, key things to remember is that the nerve roots come out above their vertebral level. And then once you get down here, so you have no C8 vertebrae, but you have a C8 nerve root. And that's where it starts, that once you get to T1, C8 comes, then you start having the vertebrae, the nerve roots come below the vertebral level, okay? And then also remember that the spinal cord ends between L1 and L2, usually at that kind of intervertebral disc space there. So here's the significance of where those nerve roots come out of. So let's maybe change the color here. This is a nerve root coming out, okay? Let's just pretend this is C5, this is C6, okay? So in the cervical spine, the nerve roots come out above the vertebral level. So this would be a C6 nerve root. So if you have a disc bulging between C5 and C6, it's going to impact the C6 nerve root. So if you get an MRI report that says a C5, C6 disc herniation or bulge, you're going to expect possibly C6, most of the time C6 nerve root irritation possibly, okay? So it's going to be, if in the cervical spine, if it says between two vertebral levels, C5 and C6, the nerve root's going to be associated with the lower vertebrae in that sequence. So does that make sense? But however, if you're in the lumbar spine, we're going to say these are lumbar spine now. This is L1, L2. This comes out below their respective vertebral level. This is an L1 nerve root coming out below. So if you have in the thoracic or lumbar spine, if you have an L1, L2 disc herniation or bulge, it's the nerve root associated with the higher vertebral level in that, you know, between the two vertebral levels. So if it's an L1, L2 bulge, you might suspect an L1 nerve root compression or lesion, okay? So that's the main thing you need to understand when you're thinking about or reading an MRI report, is what you might expect from that, okay? This is all, again, review, ventral and dorsal roots. We know we have ventral and dorsal roots. Ventral are for the afferent, dorsal are for the, ventral are for the efferent motor type information and also for autonomic efferents. And then the dorsal roots are for the afferent information. We know the proprioceptive information tends to come in through that medial division of the dorsal root, and that pain and temperature through that lateral division, okay? So this here together. This is your whole dorsal root. And then it's divided into kind of a more medial division and then a more lateral division or lateral group. These guys coming in more medial, there's nice big myelinated fast fibers, axons that are associated with proprioceptive fibers. The more lateral ones are the smaller, less myelinated or unmyelinated CA deltas that are pain and temperature. Okay. When we talk about segments of the spinal cord, the segmental spinal cord area, it's really defined by the groups of rootlets which combine to contribute to the dorsal and ventral roots which make the spinal nerves. So this is what you actually see is these little rootlets here that are made up, that are composed of this segment here, and then that's what helps to define this spinal segment by where the rootlets end and begin on that spinal segment. But remember, it's not a hard line like that. It's a blurred line between these segments right here, okay? So there's a little bit of a blurred line. So when we have lesions involving levels of the spinal cord, most of the time it's not a clean cut through the spinal cord. The lesion might be oblique, it might be angled down this way, the lesion, it might extend a certain distance back into the spinal cord. It's never just like a nice, pretty, perfect lesion, unless it's totally transected, like a knife bullet goes through and totally transects that spinal cord. Most lesions are some kind of contusion, torquing, twisting, tearing of the spinal cord that's not complete, that is oblique in nature. So you can have a lesion in a spinal cord that's oblique like this, where they can be like a C5 on the left and a C6 on the right, you know, because that's such an oblique lesion as far as their level of injury. You can have two different levels of injury on different sides of their body if it's an oblique enough lesion. So this is, again, I'll review. Spinal nerves carry all the motor sensory axons of a single spinal segment and exit above the corresponding vertebrae in the C-spine, except for C8, and that's when it starts going below, and then below for the rest of the spinal column. The spinal nerves split into ventral and dorsal primary rami. Remember we talked about the dorsal and ventral rami or ramuses that come off of there. Once they go through the intervertebral foramen, once they come out of the little hole in the side of your spinal column, the dorsal primary rami, that goes to the back part of your body, the paravertebral muscles. The ventral rami to the front part of your body, limbs, anterior and lateral trunk. Remember, we have the gray and white rami that are associated with the sympathetic chain ganglion, just from that T1 to L2 region. This is a picture you've seen before, just showing you those same things there. You know, you've got the rootlets are right out here. Here's the roots and the rootlets. They come together to form right here is the spinal nerve, right as it exits that intervertebral foramen, exits that area there. So there's your two roots coming together. Dorsal root ganglion is right back here. And then once it joins into this, it splits into a posterior dorsal rami that goes back to your paravertebral muscles and skin, and also has autonomic fibers in it going to any of the blood vessels back there. And then you have, you know, this one here is your gray ramus of your sympathetic chain ganglion, and then this more medial is the white ramus. And then this is your ventral ramus going out, going to wrap around kind of, and this is in thoracic, kind of goes out around your rib cage and then wraps to the front of the body. Internal structure of the spinal cord, white matter is mainly on the outside, and the gray matter is in the middle. We've talked about the tracks, so there's these tracks that have motor and sensory information running up and down within the white matter. There's also some tracks that run just between spinal segments, these little tracks that run between spinal segments that help communicate between multiple levels, especially when you do like complex motor activity like the walking. Central pattern generators and walking involves multiple muscle groups at multiple levels, and the way you do these complex reflex networks is you have to have some interaction between, you know, L5 and S1. They have to communicate to say, you know, when is that muscle going to turn on and what's going to trigger the next wing. That's via these things called propriospinal axons. They begin and end within the spinal cord itself. They're right close to the gray matter. They're right next to the gray matter, and they help transmit information between spinal segments, where the tracks are going from your brainstem or your cerebrum down, or from your spinal cord all the way up to a brainstem or cerebrum center. So those are the tracks. The gray matter, we have the ventral horn, which is motor, there's a dorsal horn, which is sensory, then that lateral horn, which is also known as the intermediolateral cell column, from T1 to L2, is going to be where your preganglionic sympathetic cell bodies lie. And then in S2 to S4, that's the parasympathetic preganglionic cell bodies. We also have the Rexid's lamina, so you can divide your gray matter into these laminar areas, these layers. But then there's also some corresponding kind of areas that cross over multiple laminas that are kind of these nuclei, like Clark's nucleus, that can be more regional in nature. So this is just a good thing to show you. Everything in blue is a sensory pathway. Everything in red is a motor pathway. And everything in purple, closest to the gray matter, is those propriospinal pathways that allow communication between segments within the spinal cord. There is some somatotopic arrangement of certain major pathways. So here is the anterolateral or spinothalamic tract, anterolateral system spinothalamic tract. It's layered in like this from kind of medial to lateral. Starts with upper trunk, or upper limb, sorry, trunk, and then lower limb, okay? And then we also have the same type of arrangement for the lateral cortical spinal tracts. This is a motor pathway, and it has the same kind of layering in of limb, upper limb, trunk, and lower limb in this kind of medial to lateral arrangement. This is going to be significant when we start talking about spinal cord injuries and how they affect, especially what we call central spinal cord injuries that affect the center part of the spinal cord. Now, the dorsal columns back here, they're arranged, you know, with lower body more medial, lower body, and then upper body more lateral, okay? At least when you get it. You don't even add that on, though, the upper body, till you get up above in that T1 area is when you start to add on that, you know, upper body. So this is definitely, this is interesting. So this is not a great example. This is showing this as a cervical segment, because you have a nice fasciculus gracilis and fasciculus cuneatus and gracilis here, but they're showing this little lateral horn, which you typically don't see in a cervical segment because you just don't have this. There's no parasympathetic or sympathetic neurons there. You'd see this more in a thoracic segment. So anyway, sometimes they don't always get it right, the little details. This is just showing you the segmental kind of area here of the little rootlets forming to join in to form the roots. This is a nice picture showing you the layering of the coverings of the spinal cord. So really close, that microscopic layer right on the spinal cord is that pia mater. And then here's the arachnoid layer, this little end feet, and then there's a little bit of space between that pia and arachnoid, and that's where cerebral spinal fluid is flowing. So that cerebral spinal fluid goes all the way down to the bottom of your spinal cord. And then just outside of that is your dura, okay? Just showing you a cross-section through a stained actual specimen here. This would be, can you guys guess where this would be? What general region? Cervical, thoracic, or lumbar? This would be what? This would be thoracic because it's got some characteristics. It's got a small anterior and dorsal horn. It's got a lateral horn. It's only got a fasciculus gracilis. So we know we're down below, we're in the T-spine, below T1, you know, and that's how it helps us identify that. This is just showing you some cross sections starting in cervical. This is in the cervical enlargement here, how nice and big. It's a little wider medial to lateral than it is anterior to posterior. You get in, once you get into the thoracic spine, the spinal cord gets a little more round in nature. When you get into the lumbar spine, you start to see the anterior horns get bigger. You get these big anterior horn cells in there to supply those big muscles of your legs and hips and thighs. When you get into the sacral segment, things get a little less clear as far as clearly defined. The ventral and posterior horns, a little more washed out in that region. So those are just, if you see that, you could pretty quickly identify the level if you saw a cross section. Rexid's lamina. So this is the histological regions within the gray matter. Okay, this is these 10 histological regions. So when you look at it, these cells look a little different than each other, and that's how they define these 10 lamina, because they have a little different function. They receive a little different information, or they give off some different information. I have put a little asterisk next to the ones you need to know, the ones that are important for you to kind of have more memorized. So lamina 1 and 2, they tend to kind of group those together, lamina 1 and 2. The most important part of that is the lamina 2 part, which is considered your substantia gelatinosa, which processes information initially about especially pain. Lamina 1 does a little bit of that, but lamina 2 does the majority of that. Also lamina 5 does some of that, but that's more from, and also information from the viscera. So lamina 1, 2, and 5 are important for processing initially pain information, but 2 is the most important. That gets the most information initially. Lamina 3 and 4, they get some proprioceptive information. That is where the nucleus, it's also called the nucleus proprius, or lies within that region. So they do get some offshoots. So when your proprioceptive information comes in, most of it just goes straight up the back, up the dorsal columns, but there's some collaterals that come off of that, and they go to this proprioceptive nucleus proprius, and that's involved in some of that gating mechanism, because those are near the substantia, the lamina 2 there, and they can inhibit pain, because you know, when you get some of that, like when you rub your thumb after you knock it, is because you're trying to stimulate the proprioceptors in that nucleus proprius to inhibit the substantia gelatinosa, which is right nearby. Okay, so you do get that information coming in, and it's also used to modulate spinal cord reflexes that are involved with motor activity. You want to get that proprioceptive input right there, as opposed to having to go up to the cerebellum and then having to come back down. So you get some immediate influence over the excitability of your spinal cord right at that level. But it's important to have both. It's important to have the immediate and then also the cerebellar influences and so forth. Lamina 6 is also involved with proprioceptive information going there. Lamina 7, this is where the nucleus dorsalis, or Clark's nucleus, from that T1 to L2, and then T1 to L2, it's in that T1 to L2 region for unconscious proprioception. Remember that posterior spinal cerebellar tract ascends up in your fasciculus gracilis to that level. If it's coming in below that L2 region, L4, L5, S1, all that stuff comes up to that, makes that initial synapse at the dorsal nucleus dorsalis, or Clark's nucleus. Lamina number 8, there's connections to the contralateral cord, so there's axons that project to the other side of the spinal cord for allowing communication across the spinal cord from one side to the other. Again, important for these more complex spinal cord reflexes. Lamina number 9 is the cell bodies where your lower motor neurons are. That's where the alpha motor neurons are, in that lamina 9 mostly. Lamina 10 also has neurons which cross to the other side for communication between your two sides of the spinal cord. And then there's the intermediolateral horn, which is just that parasympathetic and sympathetic regions. So T1 to L2 would be the sympathetic, and the S2 to S4 would be para. That's where those cell bodies are going to lie for those, in the intermediolateral cell horn. That's the only regions you're going to see that little lateral horn. So just showing you, on this side is the Rexid's lamina laid out for you. And you can see here, here's that area number 9. This is where those anterior horn cells lie. And you can see there's like, it's divided into those pools. This is kind of more that lateral pool, anterior pool, medial pool kind of arrangement there, for depending on whether you're going to a distal limb, an axial, a flexor, or an extensor muscle. So that's that. And then here's some of those named nuclei. This is the proper, or this is also called the nucleus proprius, or what did we call it back here? Yeah, the nucleus proprius right here. That's where some of that proprioceptive information, that's also called the proper sensor nucleus. Proper, proprius, nucleus proprius. This is that dorsal nucleus of Clark that's kind of in this region right here. It kind of spans in this 6 and 7, areas here. This is the substantia gelatinosa, which basically covers mostly 2, is where this is corresponding to. Meninges we talked about. This is the coverings of the nervous system, the pia, which also forms these little things called denticulate ligaments. So when you look at the spinal cord, what kind of anchors the spinal cord within the vertebral canal, a spinal canal, is these little denticular ligaments, which are little extensions of pia that come off at each segment and then go and anchor it to the sides. And then you also have the filum terminale that comes off the bottom of the spinal cord at the bottom of the conus medullaris that anchors it to the sacrum. So that's how you get this anchoring of the spinal cord. You have the arachnoid and dura layers. So here is showing, they've pulled off away the dura. This kind of film that you're seeing here that looks almost like a spider web, you're looking at the non-removed arachnoid there, okay? You can see kind of where the cut edge is here, where they've cut away the arachnoid there from here down. So all you're seeing here is the pia, which is microscopic. You're really not seeing it, but that's what's on the spinal cord here. This is the little denticulate. This is pia that comes off and forms. You can see the pia once it forms those denticulate ligaments. You can't see it on the spinal cord, but then it becomes visible when it makes these denticulate ligaments. So these are the denticulate ligaments coming off, and they project right into the dura area, then anchor that to the vertebral column inside, okay, and anchor the dura via that denticulate ligament to that. So those little denticulate ligaments. They're not true ligaments, but they're called denticulate ligaments. All right, moving on to function. Spinal cord, what does it do? It does a lot. It's not just a conduit for information between your brainstem, cerebrum, and your body. It does some processing. It has motor control and sensory modulation within itself. Okay, and a lot of that happens because of interneurons. You have the vast majority of our neurons within our entire nervous system are interneurons, and that's where you get this processing going on. Afferent and efferent information at the spinal cord level, every spinal cord level, is converging. Okay, so you have information coming in about what's happening sensory-wise. It's coming right into the spinal cord. At the same time, you have motor information coming down. They're converging at each of those spinal cord levels, and there's some modulation going on that will affect the output and the input. Okay, so you can modulate the motor output right at the spinal cord level. You can turn things up or turn things down at the spinal cord level. You can also turn up or turn down, like pain and how much pain you're perceiving at the spinal cord level. So there's a lot of modulation that occurs at the spinal cord level. And you can also, there's autonomic reflexes that occur right at the spinal cord level. So let's talk about some of these reflexes. So reflexes, most spinal reflexes involve complex networks of interneurons, and you use those propriospinal axons to communicate within the spinal cord through multiple levels. So some of these your book mentions. One of them we've talked about already is a withdrawal reflex. Is when you put your hand on a hot stove, step on a tack, and you quickly withdraw from the stimulus. The interesting thing about this reflex, it will vary sometimes depending on where the stimulus is located. So if it hits the bottom of my hand and I'm like this in a weight-bearing position, you know, I'm going to pull maybe straight back, but I also might put this hand down to keep myself from falling over, depending if I'm really bent over. That's the cross extension part of it. But if the stimulus happens here on the top of my arm, I might pull back this way. That's still a withdrawal reflex, but it's different than this. So our bodies are pretty good at understanding which surface it's touching and which way to move the limb a little bit. It'll modulate that reflex. And this is all happening at the spinal cord level without me thinking about it. It'll depend on the surface that I'm touching, okay, of what happens. This is the classic step on the pin right here. Ouch, that signal comes in through the dorsal root. It will ascend. This is in that intermedial lateral cell column, which is considered a propriospinal conduit or a propriospinal axons that can go up and down multiple segments. So you're going from S1, the bottom of your foot, but you're ascending and you're communicating with these multiple spinal levels, crossing over if you need to, and then interacting to create signals to muscles to say, hey, pull that leg up, but I have to balance on this leg, so turn on the extensors on this leg, turn on the flexors on the opposite leg, and that's all via this complex network of efferent and afferent inputs to the spinal cord and interneurons. Now let's talk about inhibitory circuits. So these are circuits that primarily their role is in inhibition. Every output of our nervous system is some level of inhibition or excitation. These just happen to be more inhibitory. Inhibition is just as important as excitation. So we've talked about reciprocal inhibition. That's the one where when your agonist is active, you reciprocally inhibit the antagonist so it doesn't fight you or doesn't get in your way. Okay? So that's reciprocal inhibition. Recurrent inhibition is a little bit of sometimes some of these are a little like hard to wrap your head around. This is inhibitory to the agonist. So the muscle that's actually working, there are circuits within muscles that inhibit themselves. And the reason is you need to sometimes modulate your muscle activity so there's not too much muscle activity. If you're going to be doing a task, especially a task that requires really fine control and modulation, it's not just this gross like, lifting a weight or something like that, but I'm finely moving something or manipulating an object in my hand, I only want to turn on just the muscle fibers that are needed for that task. I don't want to turn on extra muscle fibers that are actually going to get in the way of that manipulation of that task. Or I don't want to turn on so many muscle fibers that I like crush the egg I'm holding or that really light piece of paper. So you actually have built-in little mechanisms so that once you start to do the task, your muscle and the proprioceptive information going back to it will say, hey, this task requires only these muscle fibers to be turned on. Right now I'm turning on too many that are nearby. I need to refine the signal so I only turn on these ones because I only want my hand to move this way or else it's going to mess up the actual task and it's too much activity or it's going to create too much force. And so actually these recurrent inhibition and these Renshaw cells act as like to focus the signal. They focus the muscle signal to just the motor fibers and muscles you need to use for that task. So they sense when there's too much activity and they limit and narrow the signal and focus the signal. They also can be used as a governor to prevent muscle damage or tetany. At some point, if you create too much stress in your muscle or it's been turned on for too long, it can get ischemic or you might risk injuring it. And these recurrent inhibition mechanisms can, boom, shut down and turn off the muscle for you to protect it. Okay? Yeah.
Is that a type of reflex? Like, if you were to hold this and it would start to slip, you would automatically grab it a little bit harder?
So if it started to slip and you grabbed it harder, that would be a facilitatory. That is a form of a reflex that would do that. If you notice the slipping, because you'd feel that shear on your hand, that would send a signal back. But that's different. That's an excitatory reflex. This is inhibitory. So if you picked it up and this was like a really soft surface, and you started crushing it, or you were gonna, you're picking up a little baby chick or something, and you're trying to modulate exactly how much motor activity. You normally would put this much, but now you got to soften that grip. This is how you might do the recurrent inhibition. Or if you're trying to like thread a needle, with a thread, and you're really trying to fine tune only the muscles that you need to get that. That's what this recurrent inhibition makes sure that you only use the muscles that are needed, and just including muscle fibers. I mean, down to the fiber level, So this is showing you the reciprocal inhibition here, where if you're firing a muscle here, like your quad, it knows based on the muscle spindle shortening that it knows it's being contracted. The muscle spindle is shortening, but there's also some tension developing in the muscle, and so it sends a signal back, and then that may go. This would go down a few levels. This would be like L4, L2 to L4, that would be here, but it'd go down to maybe S1 and inhibit your hamstring so it doesn't interfere with your quad contraction. That would be reciprocal inhibition. And you use those propriospinal axons to send a signal down to L5, S1, or S1, S2 to tell the hamstrings to turn down a little bit. This is that kind of recurrent inhibition where this is that Renshaw cell, this inhibitory interneuron, that when you actually activate muscles, there's little recurrent collaterals that go back to interneurons that if this signal is too strong for the task, it can inhibit itself and say, hey, turn it down a little bit. Even without, the cerebellum is involved with this too, but you can have regulation at the spinal cord level of some of this stuff. So the cerebellum and all the stuff works together at the same time. They all are complementary to each other. Then there's a thing called non-reciprocal inhibition. It inhibits the agonist muscle, so the muscle you're using plus the synergist and antagonistic muscle. It shuts down or reduces output to all the muscles like in a limb. It does this based on receiving afferent information coming in plus descending information. It's another method for shaping motor output but on a larger scale. And this goes back to like the whole, this is the most common maybe example of this, is like putting or batting or doing some really skilled performance under high stress. You have descending inputs from some of your non-specific pathways, your raphe and cerebrospinal tracts. You have information coming from the environment, and they're all converging on your spinal cord, and you are saying, look, right now I'm getting ready to make this putt. I have way too much tension and tone in my muscles. I need to decrease muscle tone on both agonist and antagonistic in my trunk to smooth this stroke out a little bit. And this is how that works. So that would be a form of non-reciprocal inhibition, like a way of just down-tuning your entire muscle nervous system, down-regulating it so you can use it more effectively, smoothly, efficiently, and those kind of things. So that's what we use to kind of shape big muscle output negatively or for a positive result, but we want to down-regulate things, not get it too hyped up. Okay. There's also a thing called the negative stretch reflex, where you do a rapid shortening of a muscle spindle and you get a brief inhibition of the muscle. So you take a muscle, and I've done this before. The problem is it doesn't always work the best with my patients, but it can sometimes. Like somebody's got a really spastic bicep, right? And I'm trying to stretch it out, and they're just fighting me. Tone's kicking up. I'm getting clonus and all this stuff. I might take it and go, boom, and like push their arm forward quick to shut the muscle spindle down, and you get this And also what I do is I stimulate a quick stretch of the triceps, which causes reciprocal inhibition of the bicep. And then what you do is you don't pull it back real quick, so you try to shut it down, and then you slowly go back again, then engage the limit and see if you've down-regulated the stretch reflex and the tone a little bit in the muscle. I don't find it works that often for me, but it's because it only lasts milliseconds, you know, and so you do this, and then you start to pull it back out, then a lot of times it just kicks in again. Or now that I've shortened the muscle, I've got to like stretch it again further. Most of the time what I do is you engage the limitation. If you get some clonus, I will shorten it just a little bit so the clonus goes away, and then just try to re-engage it even slower to not elicit clonus, and then I just sit there and wait. And I hold that limb, and then all of a sudden sometimes it'll shut off because the muscle spindle will habituate to that stretch. And you'll get a habituation. But I might have to sit there for 5 minutes and hold that. And it might just be like, a lot of times it's simple things like I'm holding their limb here and I'm stretching it, and simply pronating or supinating a few degrees, all of a sudden, boom, the thing releases. Because I've just manipulated the tension on the muscle spindle, and I finally got it to habituate. I reduced the pain or perceived noxious stimulus the patient's feeling. So subtle little things like that. Or I'm trying to bend somebody's leg who's got a lot of extensor tone, and I'm just fighting it. All of a sudden, I'll just kind of hold it, but then I just might do a little rotation of the hip, some flexion extension of the dorsiflexion, plantar flexion of the ankle, and all of a sudden, boom, the leg will release on me. And it's just a matter of trying to find that optimum little sweet spot of stretch without causing too much stretch, but getting then the muscle spindle to habituate to do that. This is just showing kind of that. So this is your biceps and triceps. This is like biceps brachii, brachialis, and tricep here. And all they're showing is you've got information coming in, like proprioceptive information that's converging and has connections with inhibitory interneurons. You've got, here's the rubrospinal tract coming down. You've got lateral cortical spinal tract coming down. All this information converges on the anterior horns. Some of that's excitatory, some of it falls on inhibitory interneurons. In the case that you say somebody is doing something with their arm, like putting or something, or batting, and we want to make sure that the muscle is graded in a way that's not too forceful, allows for smooth movement, you might get down regulation of agonist and antagonist. So you shut down. Right now, if I have too much co-contraction between the two to get a good smooth move, it shuts everything down. So it just tones it down a little bit so you're better prepared for whatever activity that you would like to do successfully. Also, to prevent injury. If you just get a massive amount of afferent information saying you're working this limb too hard, it just shuts the whole thing down. It just says shut it down. You're going to hurt yourself, so let's just shut everything down. Not just the agonist, but the antagonist too. Let's just shut the whole system down. We have some postural and locomotive reflexes. We have what's called stepping pattern generators. These are circuits called reverberating and oscillating circuits. They're reverberating is that once they get going, they tend to want to keep themselves going. They reverberate. And they oscillate between like flexion extension. So they're oscillating between modes, like a flexion. Usually it's a flexion extension or something like that. And then they reverberate is that once you get them going, they have collaterals that go back to the previous cell. So once you set this thing in motion, you go and you stimulate this cell, and then it has a collateral that goes back to the first cell to keep it going, okay? And you have to actually do something to shut it off. Like when I'm walking, once I get walking, it kind of keeps going until I have a signal from my brain to shut that reverberating circuit down to tell me to stop, okay? Positive supporting reactions and righting reactions. So things like when I get pushed forward and like try to extend my trunk to counteract that, or somebody pushes me over and I stick my arm and leg out to counterbalance myself so I don't fall over. Those are spinal cord type reflexes. Those are reflexes that are integrated. The spinal cord, some of those are the brainstem too. It's an integration between spinal cord reflexes and brainstem reflexes for some of those more complex. Or somebody pushes me over and I got to take a quick step to catch myself. That is mediated more at the spinal cord brainstem level. It happens so fast, it doesn't have time to go to your cortex and back down to catch yourself. Autonomic reflexes. Many functions of the autonomic system are controlled just at the spinal cord level, so just changes in basic vascular tone. That's happening just at the spinal cord level, okay, when you start to have changes in vascular tone there. Localized sweating, you know. So if you have a sweat response, you feel hot on a certain region of your body, not your whole body, not like you're going for a run in the heat, but like you know, somebody's got a hairdryer on this part of your skin right here, you can get a localized sweat response on the top of your forearm in response to that. That's mediated by just a reflex at that spinal level, okay, that can cause that type of localized sweating. The GI reflexes, basic GI reflexes, bowel and bladder function is mainly maintained by spinal cord reflexes with a little bit of voluntary control when you don't want to go. And also even erectile and sexual functions too are a complex combination of cerebral and cognitive and spinal cord reflexes, okay? There's a thing called the mass reflex, which is also known as autonomic dysreflexia. So these two terms are synonymous, a mass reflex or autonomic dysreflexia. This is where if you have a large portion of your sympathetic nervous system deactivated or no longer being properly connected to higher centers. So spinal cord injury, typically somewhere above T6, okay? If you have a spinal cord injury, that's a severe spinal cord injury, almost complete injury that blocks the signals coming from your hypothalamus and your cerebrum and your brainstem via that's called the dorsal longitudinal fasciculus, the DLF, that goes down to help modulate sympathetic control. If you lose that, the sympathetic nervous system kind of acts like your motor system. The reflexes, the tone go up. So your sympathetic nervous system kind of turns up. And if you create a noxious stimulus, it perceives any stimulus as noxious and potentially life-threatening to your survival, and that it just goes crazy. So the sympathetic activity goes haywire because you don't have the ability to say, hey, that's not really that bad of a thing or a noxious stimulus. I'm going to use my cerebrum to tell the sympathetic nervous system to tone down a little bit because I just got a full bladder. It's not a life or death situation here. But if you don't have the ability to tell your sympathetic nervous system that, it perceives that as a life or death situation. And then next thing you know, your blood pressure's shooting through the roof, your heart rate's going through the roof, and you have no way to tell it to turn down through your cerebrum and brainstem centers to kind of like modulate that. It's just like having a hyperactive deep tendon reflex because of a spinal cord injury or an upper motor neuron injury. This is like having a hyperactive sympathetic nervous system reflex, okay? The parasympathetic S2 to S4 can also have that, but it's not life-threatening. Sympathetic is what causes your vasoconstriction, the sympathetic nervous system, especially in the periphery, in your skin. If you get massive vasoconstriction in your skin, plus your heart rate goes up through the roof, that it causes your blood pressure to go up. And the only way you can compensate for that, so above the lesion, they'll get really flush because they're trying to vasodilate above the lesion to make up for all the vasoconstriction going on below the lesion, and they'll get a pounding headache because they're vasodilating up here, and sometimes that's not enough to compensate, and they stroke out, and then you've got problems. Now, I will tell you, though, just like you have this thing called neuronal shock or spinal shock, you can also have autonomic shock. So right after the injury, so right after somebody has a spinal cord injury, initially their sympathetic tone and reflexes go away for a few weeks. This is where like you can hardly sit them up because their sympathetic tone, just when they lose that input from higher centers, it goes, we don't know what to do, let's just shut down right now. And then over time it gets more sensitive and turns itself up. Your adrenal glands start to secrete more epinephrine too in general just to try to maintain your vasomotor tone. The sympathetic nervous system also starts to turn on again a little bit. but it's hyperactive to any stimulus, okay? But it takes a few weeks to do that. But initially, when you get a spinal cord injury, your tone in your sympathetic system really drops off, and it takes a little while. And that's why, as a PT, it's hard those first few weeks getting them up, just getting them to sit up without them passing out. But then after that, now you're worried that when you get them up, they still have a chance of passing out, but now they've got less of a chance. But now if they get a full bladder, they're sitting on a wrinkle in their on the chair, on their cushion, and get a noxious stimulus, then the sympathetic nervous system all of a sudden turns on and goes haywire with that mass reflex, causing this autonomic dysreflexic response. So when you're seeing a patient who's got a neurologic injury, a spinal cord injury that's in that T6 or above, and you're working with them, you're looking for, if it's an autonomic dysreflexia, mass reflex, they will complain of feeling flushed, they'll get sweaty, red, pounding headache possibly, okay? If it's hypotension, orthostatic hypotension, they get white, they do get clammy, so they can get a little bit sweaty from a clammy type feeling that they're getting from that kind of they're going to pass out feeling. And they won't have a headache, they'll feel lightheaded and feel like maybe there's a tunnel and their eyesight's getting worse and they're just kind of like going to pass out. That's what they're going to feel like. So you're looking for more of that flushed look and clammy feeling versus this red, beet red and pounding headache and sweat dripping, off of them. Spinal control of pelvic organ function. Talk about this real quick. So this is pelvic organs, right? S2 to S4, that's the parasympathetic control of your pelvic organs is through S2 to S4. And then you also have the sympathetic is coming from the segments of T11 to L2, okay? This is where you get your control of bladder, bowel, and sexual function is from. This is your sympathetic and parasympathetic control of those primary functions. So the reflexive and voluntary bowel and bladder functions. So we have both reflexive and voluntary of both our bowel and bladder. So the sympathetic nervous system, it causes relaxation of the bladder wall and causes the internal sphincter to contract. So this allows you to store urine. This is not when you're going to the bathroom, even though people think it's kind of a myth about you're so scared and then like you pee yourself. I mean, that's not the sympathetic nervous system doing that. That's the parasympathetic nervous system doing that, but it's doing it because it's saying, if I need to do something and I'm going to be under stress and move, I might as well get everything out of my system before I'm going to be running from this whatever for the next 4 hours, so that's unusual, but that's not a sympathetic response. Even though you're going to have a sympathetic response, it's the parasympathetic nervous system that gets the urine out, but then the sympathetic nervous system's turning on. So normally the sympathetic nervous system, you're not going to the bathroom. It relaxes the bladder wall and contracts the internal sphincter. The parasympathetic nervous system is for the contraction of the bladder and the relaxation of the internal sphincter. The frontal lobes, you have a little motor area in your frontal lobes that send a signal down to these areas and specifically to the external sphincter. You have an internal sphincter and an external sphincter. The external sphincter is under voluntary control. That's the one you can I can hold it, So that's what the voluntary part of that. Now for sexual function, it gets a little more complicated. So for erection of penis or engorgement of the clitoris, it's a combination of both parasympathetic and sympathetic control. For both of those, there's a reflex part of it, okay? So the reflexogenic part of that is primarily driven by the parasympathetic nervous system, okay? So for both erection and engorgement, there's the parasympathetic system, that S2 to S4 segments, that is a reflex response. So you stimulate the penis or the clitoris, and it just will happen, okay? Through that, as long as that reflex loop through those S2 to S4 segments is intact, you can get a reflex erection or clitoral engorgement, okay? Then there's the sympathetic system, which also contributes to it to maximize the effects, okay, to make it whatever, enhance the effects. And that's actually driven by some psychogenic. You actually have some psychogenic cerebral limbic control that goes down to the sympathetic fibers in that T11 to L2 region that then send a signal down to enhance or maximize that effect. So, so somebody with a spinal cord injury, a man with a spinal cord injury, if it's above that T11 to L2 region, they will often have they'll have a reflex erection, but it won't be it won't be as effective of an erection. Let's just put it that way. If it's above T11, that injury, like T6, now the signal for the psychogenic part, and they can also send a signal down to the sympathetic fibers at T11 to L2, but if they have a lesion above that, they can't get there. So now the only thing they have is the reflex part of that, which may or may not be that effective depending on the person. You know, it's not going to be as effective. If they have a spinal cord injury down lower, like down in that L1, L2 region, something like that, or even in the sacral region, although sacral region you can often get lower motor neuron problems too, but then they have the sympathetic, the psychogenic part of it that they can contribute as well, because they can still go to those areas, and then those nerve roots come off at that conus medullaris. It gets messy, because at that conus medullaris, there's so many nerve roots coming off there, and if you get a spinal cord injury right down there at that lower part of your lumbar spine and that kind of stuff, it can be messy. It's just hard to predict sometimes when you get down low. Okay, it's a little easier to predict if somebody's up here in that T10 or above. You know that they're going to have both. They're going to have a reflex ability to have some kind of some erection or engorgement of the clitoris from a reflexive standpoint, but they're not going to have the psychogenic part to help contribute to that. Okay, if it's down lower, it gets a little more messy. They may or may not have some of that psychogenic fibers left. Okay, depending on the injury and so forth. And then for ejaculation and lubrication, the vaginal lubrication, the sympathetic fibers at L1 and L2 are what primarily drive some of that. They're coming from the L1 to L2 segments. But there's also some parasympathetic fibers that contribute to that. And there's a somatic involvement. Okay, so there's an actual voluntary component to those responses as well. So it's a complex combination. You can see these things here are a combination of reflex stuff, both in the sympathetic and parasympathetic nervous system, but also have an overlay of cerebral involvement, psychogenic erection and lubrication, but also for, especially for men, for ejaculation. There's usually some voluntary or pseudo-voluntary somatic systems that also assist with that to maximize the effectiveness of it. This is just showing you some of those connections here. Here's the afferents. These are the stretch receptors that are going up to your spinal cord segments about the stretch in your bladder. Okay. This is the S2 segment, and this is just showing you there's a little bit of a lateral horn there. These are parasympathetic fibers that are going down to the bladder wall. This is parasympathetic, S2. This is going to cause contraction of the bladder wall and at the same time, relaxation of the internal sphincter. These are the parasympathetic. Okay. Now the sympathetic, coming from this L2, T11 to L2 regions, they're going to come down. They're also going to innervate the bladder wall and that internal sphincter, but they're going to have the exact opposite. They're going to relax the bladder wall, contract that internal sphincter. And then here's your external sphincter. So you have an internal sphincter and an external. So the external sphincter is actually here's the higher centers from descending cortical input. They're going to go down, I missed there we go, to the external sphincter, so you can hold it or relax it when you need to, voluntarily. Take a short break, 5 minutes or so. Come back and talk about lesions. All right. Now the clinical stuff here, lesions. This is the important stuff. Lesions of the spinal region. All right, so I've alluded to this a little bit with spinal lesions, is we have to understand this concept of what happens at the segmental level and what happens to the tract. So there's like what we call the segmental versus vertical tract lesions in the spinal cord. So whenever you damage a spinal cord, you're going to damage what's going on right there at that level. So if you have damage at C5, you're going to damage some anterior horn cells right there. You're going to damage some dorsal roots and ventral roots possibly. You're going to damage things right at that C5 level, okay? But you're also going to potentially damage pathways that are trying to go down through that level or up past that level. That's the vertical tract stuff. The segmental stuff is what happened to the damage right at that level, okay? And there's always a combination or a mixture, okay, of symptoms or signs associated with both the vertical tract part and the segmental part of it, okay? Combination dysfunction, always some combination dysfunction. It's just more evident when you're in the limb region, like the arm or the leg. It's harder to see, it's harder to pick up, especially some of the segmental lesion problems or issues at the thoracic level, because there's just not many, like if you damage the C6 region or C6 C5, C6 region, you have C6 nerve root coming out right there. You might actually damage some of the anterior horn cells and the spinal nerve coming out of that C6 region. So, but you also might damage the tracts going past it. So you could have paralysis below the level of the lesion. You could have paralysis in the muscles that are, C7, C8, below that. But you might also have actually lack of reflexes at C6. Because that C6, you actually damage the anterior horn cells and the roots coming out. And so you might actually have a mixed kind of thing where you almost have a lower motor neuron problem just at C6, but then you have upper motor neuron problems everything below C6. Does that make sense? So that's the segmental part of that, is maybe just right at that level, but then impacting everything below differently. Because those are the tracts you're damaging, the white matter tracts. So let's talk about it here. So let's talk about different kinds of syndromes. These are really important to know for board examinations. There's certain typical syndromes that you can see with spinal cord lesions, okay? The first one we're going to talk about is the anterior cord syndrome. This is where it's typically associated with a flexion injury of a C-spine, so a hyperflexion injury of a C-spine, which could happen like this, the diving incident, where the head hits here and gets pushed forward. Sometimes you dive and the head gets hyperextended. This is a hyperflexion, though. Or somebody's in a bad car accident and their head just whips forward, and you can actually get a spinal cord injury from the rapid deceleration. So hyperflexion injury. It tends to affect more of the front part of the spinal cord, which is where your spinothalamic tracts are for the tracts that are affected, but it also may affect some of the descending motor tracts and the anterior horn cells at the segmental area, okay? And we'll draw it out here and show you the picture. Vibration and conscious proprioception, though, stay spared because they're the back part of the spinal cord. So they have normal, they feel their legs, they feel everything. They feel it, but you just can't, they don't pick up pain and temperature, okay? But they still feel their limbs. They may be paralyzed down their legs, but they can feel their legs, or they feel their arms, so they may be paralyzed there. So here's a common kind of classic thing where you get this hyperflexion injury, which causes a burst fracture. This burst fracture may send fragments back into the spinal cord that maybe the fragment itself pierces through the dura and causes physical destruction or damage, or just the compression damages the front part of the spinal cord. Another key thing is what it often does is it damages the anterior spinal artery. There's an artery running down the front of that spinal cord. And if you block that artery or damage it, the front part of the spinal cord all the way down, although there's certain areas of the spinal cord that are supplied segmentally, you damage the front part of the spinal cord because you lose blood supply to that segment, but also usually a little bit down below too, until you've got another collateral artery that supplies the spinal cord. So this is showing what you might see. So here is this burst fracture. This case, it happens to be impacting, this is the anterior spinal artery. The anterior spinal artery supplies the front 2/3 of your spinal cord. Okay. However, it doesn't have to be just that. I mean, you could just have a disc bulge straight back, or a bony fragment that impacts this front part of the spinal cord and causes damage to the front part of the spinal cord. But what I want you to notice, if you do wipe out this front 2/3 of the spinal cord, here's what you're going to have problems with. So you're going to have track signs. These are the vertical tracks that are damaged. Right here and here. That's your spinothalamic tracks. On both sides are damaged here. Okay? So this, let's say this is a cervical spine here. So let's just say this is C6. So remember, we have some overlap of dermatomes. So probably about C8 and below, you're going to have no pain and temperature. Because remember, like C5, C6 dermatomes, they overlap up to 1 to 2 segments. So you may get overlap of C6 all the way down to the C8 dermatome. There's a lot of blur between the dermatomes. So once you get below C8, whatever, you're going to have no pain and temperature on both sides of the body. You're blocked both spinothalamic tracts here because they're damaged. Information can't get past that going up. Does that make sense? However, back here, your dorsal columns are doing just fine. So all the proprioception coming up from below the lesion and above the lesion makes it by just fine. So you touch their leg, they can tell you where their foot is in space, and which is kind of weird when they're paralyzed, but they can feel. Problem is they don't have pain and temperature, which is a problem, because then they still get skin breakdown and those kind of things, because they don't know when they're sitting on their bottom too long. They can feel their bottom, but they just can't tell when it's actually causing enough pain that they need to shift their weight to keep from getting a sore. Okay. The other thing they're going to have is they're going to have the more vertical track signs. Here is the lateral cortical spinal tracts are involved on both sides. So everything below C6 is paralyzed. And it's paralyzed in an upper motor neuron way. You damage the track, so you're going to have paralysis, but they're going to have pretty hyperactive reflexes. They actually don't have a lot of resting tone, but they have really hyperactive reflexes. Because when you really wipe these out totally, and you lose all input down to those lower motor neurons, the resting tone goes down a little bit, but man, you tap on their tendons and there's no input to modulate those reflexes. They have super hyperactive reflexes, lots of clonus. Somebody with a stroke, where when you have a stroke, you don't impact all of the motor fibers. A stroke, some of those motor fibers still are going down to anterior horn cells. That causes an increase in resting tone. They also have some higher reflexes, but they're not quite as heightened because there's still some connection, but it's impaired down to those lower motor neurons. But spinal cord injury is different. Spinal cord injury, because you've totally cut off all information going to those anterior horn cells below the lesion, your resting tone is actually down a little bit, but as soon as you move their limb barely or stretch it at all quickly, boom, their reflexes are just super jumpy, because you've got this unimpeded just stretch reflex that has no control from higher centers. Does that make sense? But then we also have, so those are the track signs. The track signs are going to be loss of pain and temperature, both sides of the body, below the level of the lesion, or a couple levels below. So this is C6, it might be around C7 or C8 that you lose pain and temperature. Then you're paralyzed below the level of the lesion. Okay, so C6 or C7 below, you're paralyzed. in an upper motor neuron way, okay? But now, remember, we have anterior horn cells that are right here at this level that are coming out to go supply myotomal muscles at C6. You know, so these are going to supply the biceps, the wrist extensors, and so forth, okay? So they're going to be weakened, but in a lower motor neuron way. And you may actually have decreased reflexes in that area because you've actually damaged the anterior horn cells that are going to that. Peripheral nervous system is the final pathway. If you've got a peripheral injury, it always masks the upper motor neuron lesion. And so this is the segmental sign. So you actually have damage at the segments that are impacting anterior horn cells at that area that are going, or maybe even a fragment here tears it or avulses a nerve root, you know, or damages the nerve root. So you can have both lower motor neuron and regional sensory loss, dermatonal loss associated with the actual segmental damage, but then have things below that that are going to have like loss of sensation in the entire body, or upper motor neuron weakness and hyperspasticity below the lesion because of the tracts being damaged. Is that, you getting it? Sort of, kind of. But you could see when you get down like in the thoracic spine, you're damaging a few anterior horn cells that are just going to a few little intercostal muscles, or you're just damaging the sensory and fibers coming from a little segment of a dermatonal region. So it's hard to pick that stuff up in the thoracic region. It's more common to pick up this stuff when you're in like a upper limb or a lower limb where there's a specific, and you're hitting one of those main like segments like dermatomal or myotomal areas that go to your limb. You know, that C5, 6, 7, or that L4, 5, S1. You know, that's where you see the more pronounced, you know, seeing these, you know, independent kind of effects of the segmental versus vertical tract lesions. That's anterior cord syndrome. Now, central cord syndrome usually occurs at cervical levels. You don't see this nearly as much in the lumbar level. Usually caused by trauma. A hyperextension injury is what tends to cause this versus the hyperflexion injury. Or a rare thing that you'll sometimes is called syringeomyelia. It's actually this idiopathic development of a fluid-filled cavity in the middle of your spinal cord. And it usually happens in the C4 to C7, C8 range. There's like a little, for some reason, people have degeneration of the middle of their spinal cord and this little fluid-filled cavity, and it gets filled with some cerebrospinal fluid as your spinal cord essentially wastes away from the inside out, okay? And it's called a syringeomyelia. If it's a really small lesion, you'll get segmental loss of pain and temperature. And we'll show you how this is segmental loss of pain and temperature. As the lesion grows or gets bigger, then you start to get impairment of upper extremity motor function, okay? And upper extremity pain and temperature loss. And I'll show you how this works. So here is somebody who's had this hyperextension injury. And so when you get a hyperextension injury, sometimes what happens is like this, one of the vertebral bodies will actually shift and you'll get a little dislocation. And if it shifts and slides, it basically causes this pinching. And you just pinch the spinal cord. When you pinch a spinal cord, the stuff in the middle gets squished the most because you're pushing from both sides. You're getting pinched between the front and back here. And what's in the middle gets the most pressure, and that causes a central lesion, okay? So hyperextension, we're not getting a burst fracture of the vertebra that's sending fragments, you know, into that. So it just causes this pinching. So here is what we mean by a small lesion. of you get a small lesion that might be this pinching of the middle of the spinal cord or that syringeomyelia, this opening or a hole in the middle of the spinal cord. And it damages just at certain segments, right? This isn't extending your whole length of your spinal cord. So this case, it's just showing this is at C4 and C5. And if you notice, the only thing it's impacting here right now is that connection between the two halves of your spinal cord, right? So what's going to happen here, you'll notice, is this is at C4 and C5. So this is your dermatonal regions at C4 and C5. This is called a cape-like presentation. And this is a clear indicator of a central spinal lesion. If the patient has cape-like loss, because it usually happens, this injury, hyperextension injuries typically happen between C4, 5, 6, 7. And so does the syringeomyelia. That's the most mobile part of the cervical spine. So if you get a hyperextension or hyperflexion injury, it's going to happen usually between that C4 to C7 region is where you classically are going to see this. But C4, C5, it covers kind of the tops of the shoulders here and the front of your chest and the top of your back here. So it's kind of, and they might say, you almost have to test for it to pick it up because they might just notice, like, you know what, I noticed in the sun, like this feels hot, like when I'm in the sun, but my shoulders don't feel hot. My shoulders don't feel the heat, but I'm feeling the heat on my forearms or I'm feeling it on the rest of my body, but I don't feel any heat up here. Or for some random reason, somebody like touches them with a hot curling iron or a woman's curling her hair notices, hey, that doesn't feel hot anymore. But, ooh, ow, down here I feel the heat. So what happens is this is blocking the pain and temperature information coming in just at those segments. So here's what happens here. Pain and temperature is coming in from both sides, right? From C4 and C5. It comes in and it wants to cross over right away. It goes up or down a segment or two, but it wants to cross over. But it can't. It gets blocked there. Same thing from this side. It comes in, it gets blocked. It can't cross over to get into the anterolateral system. But only at those segments. Everything below it and everything above it missed that little injury in that segment. So everything, the legs, all makes it past it. The legs have already crossed over, going up the spinal cord, going up the anterolateral spinothalamic tract, and they're going right up past, no problem. If you get up above the lesion, everything comes in, crosses over, no problem, nothing, and makes it up to the brain. And so all you have with this little lesion is just loss of pain and temperature bilaterally at the segments where the lesion is. So that's purely segmental issues with this, if it's a small enough lesion. So now let's talk about when the lesion gets bigger, which is actually more common to have a little bit bigger lesion. So here's somebody who had whatever. It could be just damage, bleeding, a tumor in the middle of their spinal cord, hyperextension injury that caused some hemorrhaging in the middle of the spinal cord. This is a cervical spine here. But now what we have is this lesion, which is blocking. It's going to block pain and temperature coming in from both sides of the body at the segmental level. So we could say this is at C4, C5 like we did last time, so they might have a cape-like loss. But you'll notice that this lesion starts to extend out. This is the spinothalamic tract here. Right now, it's just hitting the upper, remember this is segmental, it goes upper limb, trunk, and lower limb. If this lesion actually extended out like this a little bit farther, they might actually have loss of pain and temperature below the level of lesion too, or just in the trunk if it didn't quite get all the way to the lower extremities. See what I'm saying? So depending how far that lesion extends out somatotopically in that arrangement, that you could have actually just loss of trunk, pain and temperature, or loss of everything below, depending how big the lesion is, or just upper limb. like this. You could have it just at the segmental level, but if it extends far enough into that, it could be a little bit low below the segmental level too. So you might have upper limb involvement down in C6, C7, C8 as well with this central lesion like that. Then the other thing you might have is you'll notice this is the lateral corticospinal tracts here on each side. And right now the lesion is particularly causing damage to the upper body. So you'll have paralysis in the upper body below the level of the lesion, but just in the upper body. So at C4 and C5, you'll have segmental loss of pain and temperature. You'll also have lower motor neuron problem, which is hard to pick up, C4, because there's not good reflexes for picking up C4. Well, you can get C5 here on the biceps a little bit. But then below that, C6, 7, 8, T1, in the upper limb is going to be tract problems that cause upper motor neuron weakness and paralysis in both upper extremities. And so triceps, if this was in C4, C5, the tricep reflex would be hyperactive. At least after the, a few weeks after this initial injury, this would be hyperactive. However, your bicep reflex may not be that. It may be kind of in between, because C6 is still affected by the vertical tract, but C5 might be affected by the segmental lesion, so they balance each other out. You get the lower motor neuron decrease in reflex, but you get the C6 upper motor neuron increase, so your bicep may seem like a fairly normal reflex. Or it might be a little low, or it might be a little high. It just depends on the injury and how much percentage of the tract versus the segments get damaged, because these lesions are never this perfect and this symmetrical, okay? So that's what you're doing there. But what you also might see is generally with these lesions, as they push out, they will like wipe out, maybe the upper body tract here, but they'll push. Sometimes there's pressure or compression, because these are often space-occupying lesions. If you bleed into the medial spinal cord, it's inflammation, there's some swelling. As the swelling pushes out, it doesn't totally wipe out their leg function, but it's enough to cause some decrease in those signals going down. So in the legs, they might not be they're not paralyzed, but they feel a little spastic to them. They don't work quite, they're just a little uncoordinated. They have a Babinski reflex. Their reflexes in their knee and their ankle might be heightened, but they can still walk, but it looks a little spastic and not quite perfectly coordinated. But their limbs, their upper body is really weak, and they're walking around. They're a quadriplegic. That's a quadriplegic walking around. Because as long as I have any kind of weakness in all four of my limbs, and it's a unique presentation where they have very paralyzed arms, but they're walking around. But even if their legs have any weakness or spasticity or tone, there's some involvement of all four limbs. They're quadriplegic. They're still considered a tetraplegic or quadriplegic. Okay? So that is a central cord lesion. I don't need to draw anything on that here. So this is the other one you've seen before, Brown-Secord lesion, hemisection of the spinal cord. Typically some kind of a gunshot, knife wound, tumor, or really unique trauma that gets that. So this is where you get segmental loss of lower motor neurons and all sensation coming in on that same side. So anything trying to get in on that side is not going to make it, okay? Or to getting out at that segment. So if the segment is, again, at that cervical level or that thoracic level, right at that level, there's no sensory information getting in right at the level, the dermatomal, and there's also no motor information getting out, lower motor neurons. Those alpha motor neurons are damaged right at that level, okay? But then it's going to block things coming up and down on that side. You're going to get below the level of the lesion, you get that ipsilateral loss of motor, upper motor neuron loss below on that same side, ipsilateral loss of proprioception, but contralateral loss of pain and temperature. So that's what this picture is representing here. This is that damage. This is at T10 here. And what they're showing here, this little black area here, that's the little segmental loss of all. They've got paralysis and loss of all sensory information, but only coming in just from that little strip of skin and muscle at that area. And you can see why that would be hard to pick up at that level, T10. There's nothing for me to test. I can't manual muscle test that, and that's such a small segment to try to test sensory. And there's overlap of dermatomes. So it's hard to pick up the segmental loss of everything right on that same side at that level if it's in a thoracic. If it's in the cervical spine or a lumbar spine, it's a little easier to pick up some of that stuff. So we're going to get loss of proprioceptive information coming in because it goes up the same side of the spinal cord, right? So ipsilateral, here's the lesions on this side. We're going to get ipsilateral loss of proprioception. We're going to get contralateral loss because, remember, of pain and temperature, because it crosses over in the spinal cord right away, and then it goes up and gets blocked. So contralateral loss of pain and temperature. And then we have our signals, our motor signals that come down, cross over in our brainstem, then get blocked on this side. So we're going to have weakness on the same side. We're going to have weakness in this limb, so that's ipsilateral loss of motor function. So the motor loss is on the same side. We're talking about ipsilateral relative to the lesion. Not to where that track started, we're just saying to the lesion. So we're talking about this contralateral, ipsilateral loss of function in relationship to the lesion. Okay, so just make sure you don't confuse that versus where the track started or stopped. It's to the lesion. So the lesion is on the left, so we have left-sided proprioceptive loss, so that's ipsilateral to the lesion. We have right-sided pain and temperature loss, contralateral to the lesion. We have ipsilateral motor loss on the same side of the lesion. That's Brown-Sequard syndrome. Next, Cauda-Equina syndrome. Cauda-Equina syndrome is where you have damage to lumbar and sacral nerve roots, and you get sensory impairment and flaccid paralysis of lower limbs, bowel, and bladder. So a Cauda-Equina syndrome is where you damage these nerve roots coming out. And if you damage the nerve roots, it's a peripheral nerve problem. Even though you're still in the spinal canal, those are now considered peripheral nerves essentially. They haven't come out of their intervertebral foramina to be technically a peripheral nerve, but as soon as they come off the spinal cord, they're a peripheral nerve essentially. And so you damage those nerves down in those lower Cauda-Equina segments, and that can be, L2, 3, 4, 5, S1, 2, 3, 4. They're all coming off at this tip here, and depending on how you damage that Cauda-Equina, it will cause lower motor neuron type of paralysis in your lower body, or flaccid paralysis, because it's damaging the motor nerves, axons that are coming off those anterior horn cells, but it's also blocking all sensory information. It's also blocking all autonomic function, especially some of those S2 to S4 parasympathetic fibers. They're going to be more affected because that's where they're coming off. So bowel and bladder are going to be affected. They're going to have a flaccid bowel and bladder. They're just like your muscles and your limbs go flaccid. If you have no reflex control of your bowel and bladder and bowel just go flaccid, which is actually worse than having a spastic bowel and bladder. If you have damage up above, and we'll get to this, up above this Cauda-Equina region or above the conus medullaris, you still have the reflex arcs intact for your bowel and bladder that you can have basically a spastic bowel and bladder, where they're too much tone in them, but they at least hold things in. They hold your urine and your feces in, and then you can do things like stimulate using suppositories or digital stimulation, or press on your bladder to get it going, or cath yourself. But if you have flaccid paralysis of your bowel and bladder, it just leaks out all the time, which is really hard for people psychologically, physically. It's hard on your skin. So, they have like special bags you can use that stick around your anus that you can use to try to catch some of that, or you got to wear a diaper. It's really hard on them because there's nothing to hold it in. It just kind of leaks out. They're prone to infections and things like that. So that's Cauda-Equina syndrome. And they have this characteristic, depending on where the lesion is. The lesion usually, so the Cauda-Equina, it's all these nerves, and they spread out, and there's lots of space in there. So when you go in and you get a really bad, usually what happens to Cauda-Equina is somebody jumps out of a plane, the parachute doesn't quite open or something, they land on their butt and they slam and just blow out their lumbar spine and sacrum and just shatters it, and that rips apart those nerve roots, you know. Or somebody's in a really high velocity vehicle accident, all they have is a lap belt on, and they have a fractured dislocation on their L5, just shifts forward on their S1 and just tractions all their nerve roots and shreds them. It's usually a violent type of injury that causes cauda equina injury, or somebody gets shot down in that area, but it doesn't usually get all those. I mean, you usually have some of those intact, so you just got to see what they present with, because they're spread out so you don't damage all of those cauda equina nerve roots. Posterior column syndrome, this is just selective damage to the posterior columns. And so this person is going to feel like they don't have sensation, like they're going to feel like their legs or their arms are blocks of wood, that they have no proprioceptive input or sensation. However, they will feel pain and temperature, because these are okay. Everything gets in here, moves past it, but nothing can get in. So everything from the lesion and down, there's no proprioceptive input coming in. These conscious proprioception. They still get some unconscious, because the spinocerebellar tracts still are getting up to the cerebellum. So their coordination isn't usually the best, but it's not as impacted as you might think it would be. But they just feel like, they just hardly can feel their limb. Now, they do have some gross sensation, because remember, the anterior lateral system also does crude touch. So they feel like, I can tell you're touching my arm. I just can't exactly tell you where, how, I can't point to the exact spot, but I feel something. I feel my arm, but it feels like a block of wood. This is just showing some destruction. This is the posterior columns here, and this is the white area is the loss of axons in that area that can cause it. The most common thing I see this now is, actually, tabes dorsalis, which is associated with syphilis, can cause that, but you just don't see a lot of people, at least in the U.S., that have syphilis. But if somebody has, there are people that have long-standing syphilis that can cause that. But AIDS can cause lesions in that area, but this is the one I see the most, is MS. MS, where they can have selective lesions and scarring just in the posterior columns. Let's just finish this, and then we'll stop. So still in this region of the cauda equina, if you have effects of spinal lesions on pelvic organ function, if you damage that cauda equina, especially that S2 to S4 region, you'll have a flaccid bladder. You've lost the parasympathetic control and the sympathetic control if it's below there, okay? You'll get no reflexive bowel emptying. You get rare ability to have reflexive erections, because you need that S2, S4 reflex to have a reflex erection. Questionable psychogenic erections, depending on if those, remember the T11 to L2 is where some of that input comes in. If you've damaged any of those fibers in the cauda equina that are down with it, you may or may not, you may not be able to get a psychogenic erection, but if you've got some of those spared, you can still get maybe a psychogenic erection, but since you can't have the reflex part of it, it's not very effective. They may have some ability to ejaculate, at least the voluntary kind of somatic part of that, if there's still some fibers from that T1 to L2 region and innervating it. If you're a woman, you will still have the ability to sense and assist a uterine contraction. So if the damage is down the cauda equina, the area that supplies your uterus for sensation and also the ability to help contract is above that. It's in the thoracic region. So if the injury is below that, a woman with a cauda equina injury can still have a normal pregnancy and still have maybe a normal vaginal delivery with an assist with the uterine contractions and feel the uterine contractions. If the lesion is above the sacral segments, okay, if it's above the sacral segments, now you have this, you've disinhibited the reflex, and now you have hyperactive reflex. If you have a hyperactive bladder, hyperactive bowel, and you have reduced bladder capacity, though, because of that, because it's kind of like having increased tone. You have too much bladder tone, so your bladder is slightly smaller, so you can't store as much urine. But then when you do stimulate your, like either they push on it or they catheterize themselves to try to get the urine out, it doesn't contract effectively. So even though it doesn't store urine, but then when you try to get rid of the urine, there's always stuff left in it because you don't have this nice coordinated contraction of the bladder. So you get left with what's called residual volumes. And they'll measure that and see how effective your bladder is between when it's full and when you try to get it out, what you have left in there. The bigger the residual volumes, the more chance you're having bladder infections because you just keep stuff, the old stuff stays in there, and you're inserting, if you're doing self-catheterization, do this, you're inserting something in there that can introduce microbes and bacteria, and then if that residual volume sits in there and you don't get it out each time, then it just can get kind of, bladder infections are one of the #1 causes of, part of that is that autonomic dysreflexia can be caused by bladder infections, and also a lot of people with spinal cord injury end up with kidney disease and can lead to serious consequences, even death, with too many infections. So that's why you get kidney problems. If you have the lesion above the sacral segments, about 70 to 93% of them still can get these reflexive erections, but they lose the ability to ejaculate. Only 4% can have ejaculation, effective ejaculation, because once that's higher up, you lose that ability of those T11 to L2 segments and the somatic part of that to help with ejaculation for men. Okay, if you're a woman, you have a lesion above T10, so if you T10 or above, now you start to lose the ability to sense uterine contractions and also assist with those uterine contractions. So it's probably going to need a C-section. You can still carry a baby, but you're probably going to need a C-section because you can't feel the contractions, you can't help with the contractions. And this is just showing you, so this is the injury here is to the peripheral nerves. And when you damage all those peripheral nerves, you no longer have any ability to have reflexes, and so you just get this flaccid, distended bladder. Okay. If you damage descending control or influence over these reflexes, now these reflexes are hyperactive. And now you get this increased tone in the bladder, spastic bladder, and it's harder to, at least you can store some urine and this doesn't leak out all the time, but it's still a problem. So we will stop there to give you guys at least 10 minutes to transition. Oh, she did. Let's get this done. I'm serious. We can get this done in 10 more minutes. So let's. You want to get this because we have to do it on Friday and then to do all the cranial nerves. So let's go to traumatic spinal cord injury causes. Biggest cause, MVA, motor vehicle accident. Sports are somewhat of a cause. Falls, 21%. The sad part is so you have these older adults that are in their 80s and have a fall, then have a spinal cord injury. That's not good, I've seen a few of those, but they don't last very long. If you get a spinal cord injury and you're quadriplegic and you're 85 years old and you're in ill health, that's a tough one to deal with. Violence, of course, is another big reason for those. Most injuries don't sever the cord, okay? Sever with an E on the end should be. Tetraplegia versus paraplegia. Tetraplegia means you just have some involvement of all 4 limbs. Paraplegia means you just have some involvement of your lower limbs, but nothing of your upper limbs. Okay, that's what we mean by tetra. Doesn't mean you're totally paralyzed. Just means you have some involvement of all 4 limbs if you're tetraplegic, or some involvement of your both lower limbs if you're paraplegic. And there's lots of tetra and paraplegics walking around, and you may not even know they're tetraplegic or paraplegic. So classification of injuries, we have different classifications. Complete injury, that's when you get lack of sensory and motor functions, and that has to include also the lowest sacral segment. So when you damage the spinal cord, everything below the level of the lesion, including the lowest sacral segments involved. And the only way you test that is the physician tests that, is they go in and they test sensation at the anus, and they also test for the reflex, like anal wink reflex. They see if the person, they stick their finger up your butt and they see, can you feel that? And can you squeeze my finger with your, and if you can't feel that and you can't squeeze the finger, you have a complete injury. That means you've got to, that means the lowest sacral segment is involved, okay? So that's what they do. So fortunately, we don't have to determine that. That's usually the neurologist that determines that. If you are determined to be incomplete if you have any preservation of motor or sensory function, including the lowest sacral segments, okay? So any level of motor or sensory function below the lesion, and also some in the sacral segments, motor or sensory. You determine what's called the neurological level, the neurological injury level. There's like an injury level, like which vertebrae were broken or damaged. That doesn't always match up with the neurologic level. The neurologic level is the last, most caudal nerve root level with normal motor and sensory function, okay? So you may have you blew out your C6, whatever, vertebrae, but your neurologic level may be C8. You know, that's where everything is normal from there down. But C7, C6, you may have an oblique injury where there's, you know, injury more C6 but extends to C7 on one side. So you may be, you can actually have, you can be a C6 neurologic on the left and a C7 on the right. Most of the time they don't do that, but if it's an oblique enough injury, they can actually, you can be graded at a different neurologic level of injury on each side of your body. Most of the time they just kind of make it the same from the whole body down, okay? There's a certain scale that's used to determine or classify injury called the Asia scale. You'll have to know, you should know the basics of that, and we'll go through that in a second. And injuries are often asymmetrical, left versus right, and also motor versus sensory. So the Asia Impairment Scale, it's the American Spinal Cord Injury Association scale. That's why it's called Asia. So you're a complete, you're an A, it's classified as A, B, C, D, or E. You're an A if there's no motor or sensory function is preserved, including the sacral segments, S4 and S5, below the level of the lesion. So loss of all motor and sensory function below the level of the lesion, including S4 and S5. Incomplete. A B incomplete is you have some sensory function, but no motor function is preserved below the neurological level injury, and this includes the sacral segments. That they have some sensory function preserved below the level of the lesion, including the sacral segments. C is also an incomplete. An incomplete C is motor function is preserved below the neurological level. So there's some motor function preserved below the level of injury and the neurological level. And more than half of the key muscles, so there's key muscles. This assessment is done very specifically. You assess certain dermatomes and certain myotomes. You basically do a myotome and a dermatome screen in a very specific way. More than half the key muscles that you assess below the level of the neurologic injury have a muscle grade of less than 3. So they have some function, but it's still weak. They can move the muscle, but it's less than a 3. A D, incomplete, is motor function is preserved below the level of injury, but at least half the key muscles are a grade 3 or more. So now they have more strength. They can move against gravity with at least half the muscles below the level, the key muscles below the level of injury. Not every muscle, but the key muscles, which they listed out. There's a whole little sheet you tear off, and you have to actually do training to become certified to actually do Asia assessment and grading on the Asia scale, and you have to go through and do that Asia examination with the patient. Not all hospitals have that. It's if you're a regional trauma center, a level 1 trauma center, you have a spinal cord injury team, then you get trained on doing this. And then E is normal. Motor and sensory function is normal, okay? So most of the time when they do research on people's spinal cord injury to help them improve walking or mobility, and those kind of when you see them doing harness supported gait and put them on treadmills, most of the time they have to be at least a C. They're not putting B's and A's on treadmills. They're putting people that have some hint of motor function at least below the lesion to take advantage of. Various disorders affecting the spinal region. Spina bifida, we talked about in the developmental stuff. We saw spina bifida, spastic cerebral palsy. Somebody was were you talking to me, Rob? Or somebody's talking about a dorsal rhizotomy over here. Yeah, Lauren was talking about somebody she knows, or a patient, or somebody she works with, or client, had a dorsal rhizotomy where they cut the dorsal nerve roots going back to the spinal cord to reduce spasticity, because you're reducing this, you're impacting the reflex arc, right? You need sensory input to go in to create that spastic response, like quick stretch and everything. So if you just cut some of the nerve roots going into the back of your spinal cord at the levels where the certain muscle groups that are spastic, you can reduce spasticity and tone. The problem is once you do that, there's no going back. They're going to have sensory problems in certain regions, so you don't want to cut it in regions where maybe they won't feel their butt, and you don't want to cut all of them. They might just cut some of the little rootlets. It's not, and they don't cut oftentimes the whole root, but they'll go in and they'll trim up and take 50% of the rootlets out, and they'll measure during surgery. They'll shock the muscles to see how responsive, like kind of that H reflex, to see how, and then as they cut those nerve roots, they can stimulate it to see if they down-regulated it just enough to get a lesser response, to decrease their tone. It's a kind of a drastic measure, and they don't do it lightly. They do it only when it's a problem with self-care for the patient, or really bad spasticity, and they think they can make a difference in their mobility and things like that. Radiculopathy, this is just a spinal nerve root irritation. You guys have heard about this a million times. Okay, spinal nerve problem as those roots come together. So it's right at that area where it exits out of the intervertebral foramen, where the two nerve roots come together to form the spinal nerve. This is just showing you the common typical thing here. So here's your nice normal nucleus pulposus within its disc and its annulus fibrosus, these layers here. As they start to get damaged, you can get pressure. This would be a bulge, and it's bulging into this particular area and impacting the nerve roots here a little bit. This would be actually a herniation, where you actually herniate outside of the wall, and the nucleus pulposus actually gets extruded outside of the wall of the disc, and that's right into that intervertebral foramen, and then you can get you start getting more profound. And then this is where it rips open. This is the extruded disc fragment, where you get this actually a fragment of the disc gets broken off, it can actually get loose, and you can see it can get severe enough that you can actually start pushing on the spinal cord. So this is where you worry about. This is when you're in the clinic and you're seeing your patient for neck pain. They've got radicular symptoms going down to C6 or whatever, and they have low reflexes here, lots of pain and radicular symptoms, lots of sensation. They're weak in their biceps, weak in their wrist extensors. And then they say something in the, this is your medical diagnosis, say, you know what, I've been having trouble going to the bathroom lately too. I just can't quite, get it going, and I also just feel like a little uncoordinated in my legs, just feel a little stiff to me. And then you go and you test their legs, and they have a Babinski reflex, and they have increased reflexes in their knees. That means they're starting to get, like, that bulge is big enough. It's not only pushing on the nerve root, but it's pushing on the whole spinal cord, and it's pushing enough on the spinal cord to start impacting signals going down your lateral cortical spinal tract. And that's enough to start causing the spastic bladder and spasticity in the lower body, because you're impacting those descending. You haven't totally cut them off. You're just pushing on them enough to irritate them enough that they start to have some upper motor neuron signs. Does that make sense? That's like surgery time. No more PT. Let's get you back to your doctor and let's have them look at that, because sometimes they don't pick it up. They go to their family physician. They complain of this. They haven't quite picked up on everything. That doctor didn't ask them. The doctor sees them for 5 minutes. You get in there. You start doing this other testing and realize, crap, this is a big, massive disc herniation that is maybe more central in nature. The disc is always going to bulge a little bit more to one side or the other, and it usually does more of a lateral herniation because the disc is weaker more laterally. But eventually, some people get more of a straight posterior bulge, or as the disc fragment gets extruded and breaks off, it can migrate and start pushing on. And this only happens in the cervical spine, because in the lumbar spine, there's lots of room. And so those disc fragments, there's the spinal cord just shifts over because there's a big space down lower near that cauda equina area, your lumbar area, the spinal canal opens up, so it just moves around. It's the cervical spine where you see this. Or the person has arthritis that pokes into the central canal and starts pushing on the spinal cord itself. MS, it can affect the spinal cord, the oligodendrocytes, the myelin around the tracts. Okay, it'll affect the motor tracts or sensory tracts in the spinal cord, and that can be highly variable. They can have a nice little lesion just in one location of the spinal cord that affects one area of their body, and it's like, wow. And then you have to put the picture together of what's going on. They're a woman in their mid-30s, and now they have this, weakness in one leg and with upper motor neuron hyperactive reflexes and weakness in one leg, and they had some visual disturbances a few months earlier where they had some blurred vision or double vision. I'm thinking MS, And then also you do a straight leg test and you pull their leg up, pull their head, and they go, oh, and they have this shock-like sensation. Now you can have this Larimet sign with any tension in the dura, so big disc bulge, and you have somebody do this where they do the straight leg and push the head down. That can cause this Larimet sign. That really just means that that's tractioning in the dura, but when you have an active lesion going on in MS and you stretch the spinal cord a little bit, it just kind of causes little action potentials at that open lesion area to kind of go boom, and it gives them the shock-like type of sensation. This is how I diagnosed my brother with MS. So my brother has MS, and he was running, and he was having all these shoulder issues and shoulder pain, and they thought, been to all these doctors for what they thought was rotator cuff injury, and he's a swimmer, and they thought it was rotator cuff, but he was having some wasting away of his infraspinatus, supraspinatus, and so forth, and then he's telling me he was running, and he was trying to check his stride because he said I was feeling like I couldn't feel my leg where it was hitting, and when I'd look down, when my leg was out in front of me, I'd look down like this, I get a shock-like sensation too. So I'm like, okay, so he's having some proprioceptive loss now in his leg because he can't quite feel it. He's getting a shock-like sensation when his leg is extended and he flexes his head. I'm like, dude, you need to get an MRI, not of your just shoulder, you need to get an MRI of your spine. And so sure enough, he had lesions in his cerebrum, spinal cord, and brainstem. So fortunately, he's doing well. He's still running and doing stuff. So, but yeah, that was kind of wild. But it took me and him going to about 7 doctors and therapists, and I just did it over the phone by just by description of him giving me those symptoms. So, because he lives in South Carolina. Last couple things here. Compression. Anytime you compress the spinal cord, tumors, any space, that's a space occupying lesion. Cervical spondylosis, so that's just degeneration where you get these osteophytes and these little hooks and crooks and crags that could poke into your spinal cord or your nerve roots. Syringomyelia, this is a rare progressive disorder. It usually happens in your mid-30s to mid-40s, okay? And this is where you get the syrinx. A syrinx is basically a fluid-filled cavity that forms in the central spinal cord, almost always in the cervical spine. The symptoms are the same as it's a central cord lesion. You have the same symptoms as a central cord lesion. So initially it would start with just a loss of pain and temperature in some cervical dermatomes on both sides. And then as it expands out and gets bigger, then they start getting tract signs, okay? This is just showing you bulging discs. Here's an extruded herniated disc. This is disc degeneration with osteophytes formation that can poke into the foraminal and foramina and decrease and narrow those foramina. You can also have central, so you can have spinal stenosis, which is just narrowing. Stenosis is narrowing. You can have canal stenosis, which is also known as central stenosis, and then foraminal stenosis. Okay, so this canal is central. So this is foraminal stenosis. Here's where you have a fairly open foramina that's allowing the nerve to come through. You can see how narrowed that is. You're getting osteophytes and degeneration, and it's narrowing that. Oh, you don't have this one? What's that? Okay, I will upload this version. So thank you, because I've noticed some people are like looking like we don't see this stuff. When did it stop? After which one? This one? Okay. So I will re-upload this new one to your. So it doesn't help you now, but so spinal stenosis, the canal, which is also central, and then foraminal, which is that side where the nerves exit there. So this is showing. Here's the central canal, but this is the foraminal stenosis. You can see how this is open here, but there's bony stuff infringing upon that that foramina. This is now central stenosis is those same thing happens, but they project more central. You can have both. You can have both central stenosis and foraminal stenosis. Okay, but now you can see how you see this encroachment. You see this gray kind of forming bone or fragments that are narrowing that central canal. If you get enough central canal stenosis, then you can definitely impact the spinal cord. Okay. This is just showing you, again, here's a normal, nice spinal cord. You've got some fat in around here protecting it as well. Here's a nice open patent area, but then here's that encroachment. Here's the vertebral body, and disc degeneration is starting to encroach back here into the canal. And you can see this flattening of the spinal cord. And your spinal cord can tolerate some pushing and flattening, but it can't. Then at some point you cross a threshold where you impact the blood supply, or you push on those axons enough that they start to have problems sending signals. And then you can see how this is nice, this really craggy formation here of the degeneration of the disc back into the spinal cord. So I didn't bring the case with me, did I? We won't do that today, but I will hand out a case. We actually will probably use this case later on when we get to reviewing for the final exam and we have to put it all together. I'll give you cases that are more spinal cord related, cases that are more on the brainstem, case on the cerebrum, where you have to kind of go through and diagnose and try to determine levels of lesions and so forth. But you'll see the Bird Barbecue chef at some point. All right, thanks for hanging in there for a few extra minutes. Glad we got it done. So we can just focus on cranial nerves. Enjoy whatever. You're done for the day. Woohoo! Go enjoy the beautiful day. Go out for a nice bike ride or something. Yeah, right.